can see that there is around about 40 odd participants. So good morning, everybody, and welcome to this iStent Technologies virtual surgical course. Really appreciate everybody giving up their Saturday mornings. We have in total around about 190 ophthalmologists registered, and very warm welcome to doctors from Ireland, UK, Netherlands, Sweden, Norway. We have a large contingent registered from South Africa and also from several of the Middle East countries. So thank you very much for giving up your time. Thanks to the Glaukos team for being on the call, and thank you very much to the presenters who I will introduce in a minute. I need to work out how to, here we go. So this course is aimed at ophthalmologists who are considering introducing a trabecular bypass service to their hospital or clinic and are interested to know more about this technique and technology has become so widely adopted in the surgical treatment of primary open-angle glaucoma. We will have Professor Peter Shah starting talking about reasons why safe glaucoma surgery is important and the role of iStent inject, particularly in this post-COVID era. So Professor Shah is a supra-regional glaucoma specialist at the University Hospitals of Birmingham, NHS Foundation Trust, visiting professor at University College London, and an honorary professor of glaucoma at the Centre for Health and Social Care Improvement at University of Wolverhampton. He is an international leader in glaucoma, only eye, and complex anterior segment surgery. He has written 6 books and published an impressive 160 papers. He's currently president of the UK and Ireland Glaucoma Society. He's a sitting member of the Professional Standards Committee of the Royal College of Ophthalmologists, and he's co-director of the Birmingham Institute for Glaucoma Research at the Institute of Translational Medicine at the UHB. So Peter is strongly committed to mentoring students, fellows, trainees, and also has a number of responsibilities with charities helping save sight in East Africa. So thank you for joining us today, Professor Shah. Next, we'll have Mr. Imran Masood talking about the surgical technique and what's involved to get started with trabecular bypass surgery and in particular iStent inject. He's going to talk about practical pearls and share some of his latest data. Mr. Masood is Director of Glaucoma at the Birmingham and Midland Eye Centre in the UK and Director of the Birmingham Institute of Glaucoma Research. He holds a post of Honorary Senior Clinical Lecturer and Honorary Consultant Ophthalmologist at the University of Birmingham. He is a leading figure, leading global figure in the MIGS surgery and glaucoma surgery. He was the first surgeon in the UK to implant iStent about 11 or 12 years ago, and has the largest experience in the United Kingdom and probably in Europe of implanting iStent technologies. He was awarded the Fellowship of the Royal College of Ophthalmologists after he completed his training at Moorfields Eye Hospital. And last but not least, Mr. Simon Duk, who's going to talk about some of the evidence surrounding iStent inject and talk about patient selection and his own experience. So Mr. Dorku is the clinical service lead in ophthalmology at the University Hospitals Birmingham NHS Foundation Trust. He trained in Bath, Birmingham and Moorfields and is a highly regarded glaucoma surgeon. So thank you very much for joining us. And a couple more slides from me. We're going to be hearing this morning a lot about iStent inject W. It is designed to restore the physiological outflow in glaucoma. Obviously, trabecular meshwork can get blocked, and this helps stent that. It's proven and predictable, extremely effective. Looking at the data, long-term IOP reduction. There are at least 8 or 9 peer-reviewed publications in excess of 5 years now with this technology. It's extremely well tolerated and has procedural consistency and predictability, is the reason why it's been so widely adopted. We'll hear more about it. I won't go into the individual stents. It's indicated to reduce intraocular pressure safely and effectively with patients with primary open-angle glaucoma, exfoliated glaucoma or pigmentary glaucoma. It's safe and effective when implanted standalone or in combination with cataract surgery, and it can be used for those patients who've had prior surgery or prior medication as well. A little about Glaukos. Our mission is to transform and improve the treatment of chronic eye diseases with novel therapies that provide sustainable long-term solutions. The company's been around for 22 years, 23 years. We're not only a medical device company, we are concentrating a lot on pharmaceutical therapies as well, and not only in glaucoma, but also cornea and retina. We are the first company to bring MIGS devices to the market. We're the market leader. 2012, the first iStent first generation received FDA approval, was launched in the US, was followed 2018 by iStent Inject, and more recently 2020, 2021, iStent Inject W. So without further ado, I would like to say thank you very much, everybody, and over to Professor Shah.
Good morning, everybody. Niven, it's lovely to see you. Thanks to the Glaukos team for inviting me to speak, and particularly thank you to the chair, Mr. Masood Imran, who's a friend of mine, and it's a great honour to be speaking alongside Imran and Simon, two surgeons for whom I have a great deal of respect. Can I just get a quick thumbs up from Niven that the sound's okay as I'm going along? Fantastic.
Perfect, thank you.
So I'm going to talk about safe surgery or safer surgery in glaucoma, and this is a little bit of a passion of mine, and I'm going to, all my talks really are very clinical, practical talks, because I'm a coalface professor who deals with a lot of clinical work. My slides, Niven, are not advancing, so just a slight little technical glitch there. Am I enabled to advance my slides? Do you know?
Oh yeah, it looked like there was a little bit of lag with Niven's slides a second ago, Pete. Maybe just to unshare and try resharing it.
Yep, no problem.
So Pete, I had the same issue. I just was able to scroll my screen down. Have you got a touch screen or use your mouse?
Yeah, let's just have another go. Here we go. So it's struggling. Let me just try maybe open the presentation again. That sometimes works.
I had exactly the same a minute ago, and then it worked by magic.
Right, so let's try again. Excellent. Isn't technology wonderful? So that's advancing for me. Is it advancing for you, Niven? Is that okay?
Absolutely perfect. Thank you very much.
So I've got a few little disclosures. Obviously, I work for a few companies, and actually in terms of the practical part of this talk, I'm going to be sharing not just my own clinical experience, but I have watched Imran right from 12, 13 years ago, developing the MIGS service in Birmingham. So I've kind of had a unique perspective of what he's done, and we run both NHS and private clinics together, where we have a lot of patients that go through MIGS surgery. And on the research side, I also co-direct the Birmingham Institute of Glaucoma Research with Imran. So I think when I speak about my experience of MIGS surgery, I've watched Imran really evolve it from day one, and I think that's been a very useful thing for me. Surgery is obviously a perfect example of elite performance, and like any elite performance, the sequence and timing of what you do is critical. So let's just take an example. You can probably tell from this optic disc, from the darker fundus, that look at this optic nerve. It's a 0.995, 0.99 optic disc, and we could say it's a male, or it could be a female, it could be African Caribbean, could be Caucasian, but the pressures are 40 millimeters mercury in each eye on maximum tolerated medical therapy. One eye, the left eye, the field has already gone with over minus 23 decibel loss. And the right eye, you've probably got an altitudinal field loss with very heavy minus 12 defect going into fixation. This patient has juvenile open-angle glaucoma, which is a blinding disease. And if you were going to manage this, it's surgical management only, really, and you'd want to use the gold standard evidence base for this patient, which would be trabeculectomy plus anti-scarring mitomycin C. And you'd want to end up with a bleb that looks very much like that picture there, which is non-ischemic, diffuse, posteriorly draining, normal surface tissues, and a pressure of 10. So you always want the right operation at the right time. And then you might ask yourself, well, what's the evidence base behind that? So for complex, advanced glaucomas, both primary and secondary, you could look to this UK evidence that I was part of with Jim Kerwin and Alistair Lockwood, which is a seminal paper resetting the bar really for gold standard surgery. And in my own specialist area of operating on African Caribbean patients through the Reggae project, you can see that we've set the bars for what people should be achieving. So for blinding diseases, particularly for the advanced glaucomatous optic neuropathies, the gold standard is trabeculectomy, and you wouldn't use iStent in those cases. And that's really important, because on your iStent journey, particularly if you're starting out, if you use it in the wrong cases, you're not going to have the success that you could have. And the point about MIGS, and particularly about iStent, of which I'm a huge fan, is that it is appropriate for many, many surgical journeys, but you've got to get the right journeys. So very broadly, when might a technology like iStent be indicated? Well, certainly one should be considering it in virtually all early to moderate disease. For example, when doing cataract surgery on patients on dual or triple glaucoma therapy. You've obviously got to have a suitable angle for insertion, and we'll talk about that a bit later. But along with Imran Masood, I happen to believe that there are a whole raft of specialist situations where I think this technology can be incredibly helpful. And I'll hope to elucidate some of those for you as well. So right at the start, I'm aware that on this call, we may have some extremely experienced surgeons, and we may have people just starting out in angle surgery. And the first pearl I'm going to give you is you need to be extremely proficient at gonioscopy. So if I use a term like you need to watch out for narrow trabecular meshworks, and you don't really know what I'm talking about, then you need to do more work on setting up your foundation before you start doing this surgery. And you need to perform as much practical gonioscopy as possible. And you know, when I was a junior doctor, I went through a phase of gonioscoping every single patient in clinic. And you don't even need to necessarily have a contact lens. You can have a kind of non-contact lens, which is really fast. But you've got to learn what the normal variation in angle anatomy is if you wish to be a good MIGS surgeon and a good iStent surgeon. And I cannot emphasize that enough. And you need to be able to identify the key landmarks in the angle. So again, you'll always know a good gonioscopist or a good glaucoma surgeon because they grade the angle from anterior to posterior. Anyone who's grading the angle from posterior forwards doesn't know what they're talking about, basically, because you can get it wrong. You have to start by beam splitting and identifying Schwalbe's line. And once you've identified Schwalbe's line, you can progressively grade all the angle structures from there. The non-pigmented trabecular meshwork, the pigmented trabecular meshwork, which is going to be critical to MIGS insertion, the scleral spur, and the ciliary body. And you can imagine that if you start implanting iStents into the ciliary body, thinking that it's the pigmented trabecular meshwork, you're not going to get the success you want. And what did I mean by a narrow trabecular meshwork band? This is very, very important. I want you to imagine that my one hand is Schwalbe's line and my other hand is the scleral spur. And there's a distance between those two of about 400 microns. And quite a few patients, that distance is massively truncated down to perhaps only 200 microns. All the trabecular meshwork structures are compressed. And that's what's called a narrow trabecular meshwork band. And it can be particularly difficult to access Schlemm's canal or to implant structures into those kind of angles. So try and identify these dysgenic angles before you start. May not be the ideal angles to start learning MIGS surgery in. And what have I learned about the angle through surgery over all the years? I started off probably about 24, 25 years ago doing a lot of goniotomies in children with primary congenital glaucoma. So very early on in my career, I got a huge feel for the angle and cutting into it and various things. And over the years, I've learned that the angle is extremely dynamic. Now, let me just give you one example. A young patient with primary angle closure, and by young, let's say less than 45. And you might have the plane of the iris and the plane of the cornea. And the point about these angles is that they can be extremely dynamic. And it's very important to understand that anatomy can not only be variable, but it can be dynamic. And this is all relevant to the ease of insertion of devices. So some angles are more accessible than others. Some trabecular meshworks or Schlemm's canals collapse if you put too much viscoelastic into the eye. Some angles have more rigidity. Some angles, it might be like putting something into butter, a hot knife into butter. Some angles, it might be like going through a fibrotic kind of scar. It's important to know that there are regional variations in Schlemm's canal. And Imran, I don't know whether he'll share it with us today, but he's done some lovely work on regional blood patterns in Schlemm's canal and understanding things like areas of focal stenosis or focal collapse in Schlemm's canal, which are critical to getting the right place to insert devices. And also you've got variable bleeding that can occur depending on where your collector channels are and the level of episcleral venous pressure. So, you know, the red eye that has severe ocular surface disease has a higher episcleral venous pressure, more likely to bleed than an eye that doesn't. And the thing that I'm kind of passionate about is brittle angles. And I coined this term maybe about 16, 17 years ago. And for me, a brittle angle is the surgeon's enemy. If you can spot brittle angles in glaucoma surgery, you're going to save yourself and the patient a lot of heartache. So for me, a brittle angle is one that has reduced functional reserve. It may look quite normal, but it's prone to intraocular pressure instability with sudden, unpredictable, intermittent, very high pressure spikes. And I'm going to give you an example of that a bit later. So what kind of angles might be brittle? Well, starting right from, children, primary congenital glaucoma, Axenfeld-Rieger's, anterior segment dysgenesis, then moving through the teenage years, the juvenile glaucomas, moving into the 20s and 30s, you've got your depositions, pigment dispersion syndrome, PXF, trauma, angle recession, aphakics, then you've got into your 30s and 40s, you've got inflammation and angle closure, steroid responders, high myopia, and even long-term polypharmacy, which we're now beginning to understand actually changes the morphology of the trabecular meshwork itself. And a brittle angle can decompensate very easily. You might do a very good phaco on a brittle angle, and it might be a perfect phaco, but the pressure will be 50 the next day. And you don't want that to happen. Laser procedures, even a posterior capsulotomy, can decompensate a brittle angle. Use of steroids and obviously inflammation. So any stress will decompensate these angles. And the point about knowing that an angle is brittle is it enables you to use the correct choice of operation. So, for example, if you were doing a phaco in a brittle angle, you would really want to ask yourself, should I be using a MIGS procedure like iStent to blunt the anticipated pressure spike? Should that be our new standard of care? Well, we might talk about that a bit later. I happen to think it is. So if you know an angle is brittle, you can get the right operation, you can consent the patient properly, warn them that the post-op course might be a little more stormy than usual, get the right frequency and potency of steroids, and follow the patient up at the right frequency. You might see them a bit sooner, even as soon as day one, if you thought they had a brittle angle. And of course, supplementing with extra glaucoma therapy post-op. So we've got brittle angles, and at the other enemy of a glaucoma surgeon is a brittle optic disc. This is an optic disc that is just hanging in there, but is waiting to wipe out. And we all know that there are certain features that we see that correlate with a higher risk of wipeout, particularly advanced visual field loss, split fixation, reduced acuity due to glaucoma. These are things which can really put you at risk of wipeout. And again, if you were doing a phaco on an eye at high risk of wipeout, you may want to augment that phaco with a technology that blunts post-op pressure spikes. So for me, this is how I would kind of think about the role of MIGS, particularly iStent in the post-COVID era, certainly in early to moderate disease. That's the indication. And I would say, consider it in every single case where you can reduce polypharmacy, particularly in the elderly, particularly in those with ocular surface disease, particularly in those with drug toxicity problems or who are going to struggle with follow-up or intensive follow-up. All those patients where you don't want a high pressure spike post-op, those brittle angles, I would consider iStent technology. Number two, severe OSD or acute OSD, where you really need in the long run, you need to do a trabeculectomy, but you know that if you do a trabeculectomy right now, there's just going to be huge scarring. So you can use iStent technology as a bridge to filtration surgery, where it allows the ocular surface to heal with reduction of medication, particularly glaucoma medication after phaco. Then you've got more specialist areas. So I hope Imran will talk a little bit about high-risk cataract surgery, pigment dispersion, PXF, severe glaucoma, brittle angles, steroid responders, only eyes. We just don't want pressure spikes in these eyes. And I think iStent technology has massively reduced post-op pressure spikes. It's made our life a lot easier. And then finally, you've got very specialist areas like advanced disease, where there's a high risk of wipeout. And again, I think you could consider iStent technology. So I'd like to give you a very real couple of cases. Case number one was performed by a colleague of mine in the Midlands who is a superb surgeon. They operated on a 63-year-old male, and the team missed megalocornea. The horizontal corneal diameter was 13.0 millimeters. Because they missed megalocornea, they missed the occult pigment dispersion syndrome. Why would you go near someone unless you were thinking about it? So doing a phaco on someone with missed pigment dispersion syndrome The pressure was 50 post-op, and like many of these cases, did not come down, was extremely refractory and required a further 4 glaucoma filtration procedures, after which there was significant visual loss. The second case is a very similar case, and I always think of these two cases together. The second case was a 73-year-old male with pretty heavy pigment dispersion syndrome, 3+ goniopigment, 2+ Krukenberg spindles, severe ocular surface disease, deep-set eyes, tight orbits. These are not the eyes you want to do trabeculectomies on. The patient had bilateral phaco iStents by Imran Masood in this case, and I have seen this patient 7 years down the line with visions of 6.5 unaided and pressures of 11. And that really is a tremendous victory. You know, I think these technologies are helping us to do things we couldn't do a decade ago. So my messages are very simple. We all want safe surgery. The more tools we've got in our toolkit, the safer we'll be. We have to use the right tools at the right time. And I would really commend all those surgeons who want to go on the MIGS iStent journey to really pump prime yourselves and spend a bit of time really learning gonioscopy. Make sure you understand the angles, and then the MIGS surgery will go very well indeed. Thank you.
Peter, thank you very much for an excellent introduction to the subject, and some great pearls and great points there. I've got a question that's come through. So the question again, I know you've got massive experience of doing SLT, so it's in relation to SLT. So the question is, does SLT cause the angle to become more brittle or more likely to cause the iStent to fail?
That's a great question. The honest answer to that is I can't give you an evidence base to back that up. I can't quote a paper or anything, but I can give you my own personal experience. And my own personal experience, and certainly perhaps my experience of working with you, Imran, as well, over 12 years where we have literally put hundreds and hundreds, if not thousands of patients through SLT and iStent technology, I haven't personally found that it prejudices the outcome of surgery to have SLT before. I would say in a very small number of cases, I have seen a little bit more inflammation than you'd want post-phaco. And I sometimes wonder, Imran, whether some of those SLTs were done by junior surgeons that perhaps SLT'd the ciliary body a little bit too much, or the iris root. But certainly in my own experience, I haven't found that SLT prejudices the outcome of iStent technology. Have you?
No, I agree with you. And I think, as you know, we share a lot of patients that perhaps have had SLT under your care, who I've subsequently then done iStents on, and I've certainly not noticed that. And I think that's the beauty of SLT. It's actually a very safe and gentle procedure. So I would say that actually it's something that I haven't seen. Now, what's interesting is that, just to take this discussion a little bit to the side, a little bit lateral, there has been discussion around, for example, if you're going to viscodilate the canal with alternative surgical methods, can you combine that with SLT? So can you viscodilate plus do SLT? So I think SLT might actually prove to be an adjunctive therapy in some areas of MIGS, and people have certainly talked about this. There's no evidence for this, but so I certainly don't think that the SLT causes the angle to become more brittle. And if I can sort of extend that a little bit with your, I suppose, greater experience in laser of the angle, do you think ALT? I mean, I have no experience of ALT because I've only ever used SLT. I know there may be there's a lot of international people on here who might be using ALT, for example. Do you think ALT can make the angle more brittle, or perhaps, maybe badly done ALT certainly can, I think.
That's another really good question. And the way I'd answer that, Imran, is before I started doing SLT, so I've probably been doing SLT for about 14 years now, because I was an early adopter. So I'd probably done another 12 years of ALT before I did SLT. And I'd got to the stage where I'd done so much ALT that I was experimenting with power settings. And towards the end of the ALT era, we were using ultra low power ALT to see if we could get the same results. I have to say high power ALT, I do think caused angle fibrosis in some cases. And you'd even get little peripheral anterior synechia sometimes. I do think it made the angle more brittle because I think it was more destructive.
Yeah.
So that was my own personal experience.
Okay. So I've got another question here. So what you're saying is that you recommend that we should insert an iStent in all brittle angles. This means that a lot of our patients need to have an iStent inserted at the time of cataract surgery.
I'm going to give you a straight answer to that. Yes, I do. And that's based on, you've got to remember that perhaps the majority of my surgical career, my whatever number of years it is, 30 plus years of ophthalmic surgery, we didn't have these technologies. And I can tell you, going back 20 years or so, or even in the early days of phaco in the early 90s, in brittle angles, you would worry about big pressure spikes. And it was a big problem for us when it occurred. You might have to go to trabeculectomy surgery early, which is something you really didn't want to do. And, I can only share my experience of working with you over the last 12 years, where I can almost not think of patients who've had very severe pressure spikes in brittle angles post-phaco. I mean, can you think of any cases that we have had those big pressure spikes?
No, I think it's not common. And in fact, when during my talk, I'm actually going to talk about this whole concept and share some of our data. But I do think it's made a big difference. I mean, obviously, there's other things like clearing out viscoelastic properly and all these other issues as well, because actually IOP spikes post cataract surgery are multifactorial. And use of appropriate viscoelastics, I think that's another important point. But particularly if you use dispersive viscoelastics, you've got to be very careful because they're harder to remove from the angle. So there are all of these kinds of issues. And it goes back to this point about when you have less functional reserve in the angle. I think that's a really important concept because when you have less functional reserve, your angle won't clear viscoelastic as easily. You really have to go in there and make sure that all of the angle is clean of viscoelastic, otherwise you will get pressure spikes. But I would certainly say what I found is that, and I'll give you an interesting example of a patient that I dealt with literally 3 or 4 days ago, quite an elderly gentleman who was referred to me quite urgently with a phacomorphic cataract in his only eye and a pressure of around 30 on a couple of medications, and with fairly advanced disc damage, a really moth-eaten damaged disc. And we did a phaco and iStent on him. Now, the problem with this gentleman was he was squeezing his eye during surgery. The surgery wasn't straightforward. It was a small eye, and we started to get a lot of iris prolapse towards the end. And in the end, I had to leave a little bit of helon in the eye, just over the iris, to keep it from prolapsing. And there was a little bit of blood in the eye as well, because I actually had to do a very small surgical iridectomy where it just kept coming out, and I had to get the side closed. And then remarkably, immediately post-op, so I saw him about 2 to 3 hours post-op just to check. His pressure was about 15, and the next day it was 12. I mean, I'd given him one tablet of Diamox. But I think that if I hadn't used the iStent in that scenario, I think I would have been dealing with something a lot more complicated. I mean, you can imagine from your past experience, you imagine you've had iris trauma, you've got a bit of blood in the eye, you've got a bit of viscoelastic in the eye. You're really talking about pressures of 40, 50 potentially. And in an only eye patient, that's not really what you want. So I think in that scenario, that was literally 3 days ago, that rescued the patient, I think.
Imran, that's a great, yeah. I mean, you know me, I have a few of my kind of Shah's rules and Shah's equations, and viscoelastic plus blood equals pressure of 50,
yeah.
And so I think that's a really, I love this kind of elite surgical anecdotes because they actually guide us. You never get this out of a paper, or this is the real world, what we have to do every day. And, another thing which I jokingly say, but which is actually true, is that during a phaco, the longest part of the operation for someone like me, for a glaucoma surgeon, is going to be the removal of the viscoelastic at the end, the IA, because if you leave visco in any eye, particularly brittle angle, that's when you're going to suffer.
We'll just see if there's any more questions here.
Imran, there's a couple of questions in the Q&A.
Yeah, there's a couple of questions here. So thank you, panelists. Who should do this surgery? I think that's a question we will talk about a bit later on. The question is, who should do this surgery? Glaucoma surgeons only, or should any intraocular surgeons do this? I'll perhaps answer that question later on. And Niven, please remind me if I haven't. How do you convince an unwilling district hospital to permit trial intervention adoption of iStent because of its financial cost? Again, I think we can cover that a bit later on, Niven. So if you keep a record of those two questions, we'll cover that a bit later on. They're very, very, very important questions. But what I'll do is, Peter, thank you very much. I think, excellent talk as always. I know you've given this talk a few times before, but every time I hear it, it gets better and better. So there's some great new pearls there. Right, I'm just going to share my screen now. Just 1 second. Okay, Niven, can you see my screen?
Yes, I can.
Okay, thank you.
Commence.
So I'm going to talk about the technology itself. I'm also going to talk about a little bit of background anatomy and physiology, and then I'm going to give you my sort of own clinical perspective on where I think the trabecular micro bypass technology using the iStent inject is so powerful. So I'm just going to mention the iStent inject. This is the sort of original version, and this is the more updated iStent inject W version, which is now the one that's really being sort of marketed, and surgeons are being encouraged much more to implant this. And there are reasons for this, and we will talk about that. So why am I a big fan of trabecular micro bypass, in particular using the iStent? There's lots of technologies out there. But I do feel that the reasons why I use this technology in my patients is really, they're all listed here. It has the highest safety profile of any MIGS procedure out there. So like I said, there are countless numbers of angle procedures, but this is really the safest. It really targets the site of pathology. The recovery is very, very rapid. You don't get big high femurs. You don't get significant inflammation afterwards. There is zero post-operative intervention. You really do not have to do anything in terms of post-operative maneuvers. And I think it's an excellent adjunct to cataract surgery in glaucoma patients who are in the eye already. And it adds about, once they're experienced, from my perspective, it adds literally about 5 minutes to the operation. Obviously, when you're early on in your learning journey, it might take a little bit longer, but nevertheless, there's very good evidence from the literature that it doesn't add anything in terms of risk to your cataract operation. So when you're consenting patients for iStent, you can quite easily say that the risk is exactly the same as if you were having the cataract surgery alone. So that's a really important point. So one of the other important points about the iStent is that the head of the stent will sit here in Schlemm's canal. And again, you cannot get hypotony because the aqueous veins which come off Schlemm's canal and the other drainage pathways within the sclera, there is a floor to the level of the pressure. So the lowest pressures I've seen with the iStent are around 10 millimeters of mercury. And often that's with adjunctive medication, but you're not going to get pressures lower than 10 because 8 to 10 is, or 8 to 12 millimeters mercury is what is the pressure within the episcleral vasculature into which Schlemm's canal drains. So you cannot get hypotony with this procedure. The other great thing is that there's a huge amount of redundancy in Schlemm's canal and the trabecular meshwork pathways. This is something that we're beginning to learn, that actually by the time the trabecular meshwork fails, a lot of this system has started to degenerate. And the disease process within the trabecular meshwork may have actually started a decade earlier, but because there is lots of redundancy in the system, as there often is in lots of biological systems, that by the time you start to get an increase in intraocular pressure, probably 80–90% of the trabecular meshwork has become damaged and dysfunctional. What's interesting is that if I take one aqueous vein, one aqueous vein can carry away 1.2 microliters a minute of aqueous humor. So 2 aqueous veins can actually carry away the entire amount of aqueous humor that is produced by the ciliary body in that time. So it does, again, really highlight the redundancy in the system and the fact that the system has tremendous capability to compensate. So another very important anatomical point, and this goes back to something that Peter Shah was talking about in terms of the size of the trabecular meshwork. So you can imagine if the trabecular meshwork size varies, the size of all the other structures within the angle can vary as well. So if you have a look at this very nice OCT study, which looked at the Schlemm's canal, you can see Schlemm's canals of various sizes. Look at this here, very, very large Schlemm's canal, and you've got a very, very small Schlemm's canal. So when you're thinking about which is the ideal MIGS device to use in different patients, be mindful of this. You might go in, you might think, oh, I can implant a certain device in the angle, and you may find you can't, simply because the anatomy does not allow you to do so. And so one of the things that I really like about the iStent is that the iStent is small enough to fit into any sort of canal. I think that's a really important point. So you don't have to think too hard about this because the head of the stent is actually very, very small. The Schlemm's canal can be slightly variable in terms of its location. You can see again, there's, this one is slightly further back, this one is slightly further forward, and you have Schlemm's canals of various shapes as well. So all of this anatomy and being aware of this anatomy, most people are not aware of these anatomical variations. Just be mindful of those, and that might be the reason why implanting a stent in one eye seems easier than another. It might be due to the underlying anatomical variations. And the collector channels which come off Schlemm's canal also vary in terms of their location. So these are collector channels coming off on the lateral side here. These are coming off more centrally. Just to reorientate you, this is the cornea here. This will be the iris down here. This is the AC. And this in this diagram, the collector channels coming off the middle, and here they're coming off on the medial side. So again, tremendous variation. So this just is demonstrating the concept that Professor Shah mentioned earlier, is that there is a lot of variation in angle blood reflux patterns. This is a patient who has quite advanced pseudoexfoliated glaucoma, and there's a very nice thick bloodline. And that's interesting because other data in the past has shown that perhaps if you have more advanced glaucoma with higher pressure, the bloodline is more faint, but we've certainly not found that. So here's another example. This is a very highly myopic patient with primary open-angle glaucoma. And you can see here that you've got a good amount of blood reflux here. You've got less blood reflux here. So this may be a point where there is a collector channel directly behind the canal. And so this is the kind of place you want to aim with in terms of your iStent. And probably you don't want to go over here because there might be an area where the canal is fibrosed. And even it may be that it's collapsed, and so you may not be able to get the head of the stent into that part of Schlemm's canal. So if we carry on, this is a patient, this is actually the G1 stent. This is someone with a very thin bloodline. Okay, this is a patient with more of a juvenile type of glaucoma with a background of retinitis pigmentosa. And you can see that the Schlemm's canal or the trabecular meshwork height is much, much smaller. That's, again, what Professor Shah was talking about. I'll just carry on to the next one here. Okay, so this is interesting, sorry. So this is a patient who has had a failed trabeculectomy and was due to undergo cataract surgery, is on 2 or 3 medications. And you can see that even in the context of a failed trabeculectomy, you're getting blood reflux into the Schlemm's canal. So this idea that Schlemm's canal collapses and becomes dysfunctional in patients who've had an external filter done is not substantiated, really. And I'm just going to move on from here. So we know medical management with glaucoma works. There is good evidence to support this, but the problem with medical management is persistence and adherence with topical therapy. And this data you can get from American studies where patients who have to fill in their repeat prescriptions, you can get that data, and you can see that here, the months after treatment initiation with diagnosed glaucoma, very, very quickly the pharmacy renewals drop off. Okay, so with the beta blockers particularly quickly. So the point here is that patients do not take their medications properly. Okay, and that is a really important point to make, because that does push us towards thinking about glaucoma in a more interventional way, where we take away this the responsibility from the patient, because actually putting drops in the eye is not easy, and it has side effects which the patient doesn't have prior to the diagnosis of glaucoma. And this is another very important concept. The success rates of combined phaco and filtering surgery is usually not as favorable as filtering surgery alone. Very, very important concept. Peter Shah mentioned this idea of bridge to filtering surgery, a concept that I've coined. Now, the problem is, if you go back 25 years, there was always this discussion in various meetings. And I remember, going to college congresses and other meetings where people were always trying to, with glaucoma surgeons, the only interesting thing they could really talk about was, shall we do a phaco first and then a trab, or shall we do a trab, then the phaco? And in both cases, it was difficult to actually work out what to do. And you had to vary that depending on the patient in front of you. And we know that the success rates were less than that of trabeculectomy alone. So we know also that if you do a successful trabeculectomy, that cataract surgery after trabeculectomy has a profoundly detrimental effect on trabeculectomy function. There's good literature to support this. And what they say here, this is a paper from Pencor, that this risk is increased if the time between trabeculectomy and cataract surgery is shorter. And I would certainly echo that. In my practice now, fortunately, I do not do many cataract operations in patients who've had trabeculectomy, but when I do the odd patient, the trabeculectomy function is affected. And this is really the real bugbear of glaucoma surgeons, is an eye that looks like this. If you have an eye that looks like this with a high pressure, that is a really difficult scenario to deal with. And this is where I think angle surgery is extremely powerful. And I'll give you some example of that in a minute. Now, imagine if you operate on an eye like this, do a filtering operation. And what will happen is you will get an intense post-operative inflammatory reaction. You'll get intense amount of fibrosis, and your trabeculectomy, the risk of trabeculectomy success in an eye like this is very much reduced. Really, you want to be operating on an eye that looks like this. And so the idea behind using the iStent as an adjunct is that you reduce medication load, you can improve the ocular surface, and then you get better outcomes with filtering surgery. And the idea here is because you get good lowering of the pressure as well, it buys you time to be able to get the eye to that state, so then you can operate and get a good result from a filtering operation. And an example of a patient. This is a patient who's had a trabeculectomy on one eye and still on drops in this eye, and you can see very, very marked difference in the degree of ocular surface disease. And a really important study, this is from Canada, from Catherine Burt, and what this study really shows is that the success rate of filtering surgery really drops off as you increase the number of back preserved medication, okay? And so this idea of drops having a negative impact on filtering surgery, again, goes back to this idea that you really want to be filtering people on minimum amount of medication. And, a lot of these patients, what I'll do is if they come to me on preserved medication, I'll do a phaco plus iStent, I'll switch them to preservative-free medication, wait, and then think about doing a filtering operation. And in terms of initial patient selection, I know Simon's going to talk much more about this in his talk, so I'm just going to mention very, very quickly. I would go for patients who initially have mild to moderate glaucoma, who are on 1 to 3 medications, and their IOP is well controlled, because in this scenario, even if the iStent positioning is not quite right, you're not going to get a detrimental outcome in terms of IOP control. So again, let's talk a little bit about why the iStent inject. I've kind of mentioned already that I think it's the safest device. It is also the smallest device. I think this is very, very important. And I know Professor Shah mentioned some of the rules that he comes up with. I've come up with a rule with respect to MIGS. And that is that if you put a device into the eye, you have to be able to take it out. I think that's a really important concept for any device that goes into the human body, because you might get infection, you might get other complications, and the device has to come out. And we've seen that with this particular device, the CyPass, that there have been hundreds and thousands of these implanted around the world. The CyPass was then subsequently withdrawn due to problems with endothelial failure, and you cannot take these out. You have to basically amputate them because once you get fibrotic growth through the little outlets here in the suprachoroidal space, you cannot take them up. I've managed to take one out. In one case, we tried to pull on the head of this, and it felt like the whole choroid was going to come out. So, you really have to think about this idea. If you put a device in the eye, you've got to be able to take it out if there's a problem. So, whenever you're learning a new technique, you've got to have a good background knowledge of the anatomy, the physiology, the pathophysiology of the disease you're looking at, indications for the procedure, contraindications. You need to practice in a simulated environment. You ideally want to observe a skilled practitioner live, and then try the technique in low-risk cases with fully informed consent. This is how I would start off my journey. So the next thing is to keep a careful log of and audit of all of your cases. Speak to experienced colleagues, and above all, stay safe and don't harm your patient. How do you become skilled? Well, it does take time. You need to buy yourself a modified Swan-Jacob gonio lens. There's lots of these different ones on the market, and Glaukos have lots of disposable ones as well as reusable ones that they can provide. And really, when you're starting off at the end of the phaco procedure, remove some viscoelastic and just have a look at the angle. Turn the patient's head 40 degrees and then tilt your microscope by about 30 degrees and pop your gonio lens on and just get a view of the angle. So this video that I was part of a number of years ago, we did a live iStent masterclass. This is me doing live surgery. And this is just showing you that you have to turn the head, and then we're turning tilting the microscope towards us. We lift the oculus up, and you have to drop your chair down as well a little. And then that gives you a view of the angle. There's the angle and this is a pseudo-exfoliation case. Those are ideal cases really, because you know exactly where the landing zone is for your iStent. So I'm going to move on to talking about some of the surgical pearls and give you some of my sort of tips and tricks that I've learned over the years. This is the original iStent Inject. This is the iStent Inject W, which Niven has already shown you. And the advantage of using the iStent Inject W is that with this wider flange, overimplantation is less likely. It's not unlikely, but it's less likely. And I will show you an example of a case where we did get slight overimplantation, but these are very easy to deal with. This is the trocar itself. This is the original one. Let me talk about the Inject W. So there's your trocar. This is what you use to pierce the trabecular meshwork, and then you have the two stents loaded onto the trocar, and then you press the button to deliver the stents. And that's something that you really need to get a feel with your local Glaukos rep. I can't talk too much about that in terms of what it actually feels like, but that's something you need to kind of handle the actual stent and the delivery system to get an idea of how to use it. So let's look at some cases. This is actually an iStent Inject case. And I'm just going to go through the phaco. We don't want to bore you with the phaco. So there's the sort of view we're looking at. And then we put on the gonio lens. We've put some viscoelastic on the eye to act as a coupling agent. And you can see here now, so I'm just going to stop here. This is a patient who's had previous angle closure, and therefore the trabecular meshwork is very, very pigmented. And when you take the lens out, you get deepening of the angle. So, you can go in with an iStent in these cases. So the principle is the same, but this is the iStent Inject. So I'm going in with the trocar, just probably on the anterior side of this pigmented area. So you want to go in just below the non-pigmented TM, almost at the junction, and then you press the button and the stent is delivered, and you get this little reflux of blood through the inlet of the stent, which tells you that your stent is well positioned. You move a couple of clock hours across, and again, put the trocar through that junction between the TM, the pigmented and non-pigmented, press your button, and come back out, and you'll see again reflux right through the actual inlet. So you know that the stent, and that's a perfectly placed stent there. And then you've got another one here. You wash away the blood, you can see that they're very nice. Now, how else do I know that these stents are perfectly placed? Well, if you look around here, this is the episcleral vasculature. When I inject BSS, you can see the whole area has become blanched. So this, for me, is an excellent endpoint, and I'm just going to pause here. This is an excellent endpoint to tell you as a surgeon that you've hit the spot. And in that kind of patient, I know I'm going to get a good result. Now, what about more complex cases? So this is a patient who was sent to me, got a very dense cataract, has had 1, 2, and there's a third iridectomy there. This patient's had 3 previous trabeculectomies, okay? And you could think, well, how are you going to use an iStent in this scenario? Well, I'll show you. This patient came to me on about 3 medications, fairly advanced disc damage, pressure around 23. And these patients are difficult to deal with. Some surgeons would say, well, you have to put a tube in first and then do a phaco. But actually, no. When you are more experienced, I think the angle surgery is very helpful in these cases. So we're just going to again just go through the phaco quickly. It just shows you really that it is a very dense cataract. IOL is in the bag, right? So let's have a look at the angle now. You can see the iridectomy through there. Okay, so I'm just sorry, this has gone back. So I'm going to just, okay, so now the point about this angle is that because of the previous trabeculectomies, the patient has developed peripheral anterior synechii, okay? So around the iridectomy, you can see that the angle is adherent to the trabecular meshwork, the iris is adherent. So what I'm using is I'm using a micro grasping forceps to conduct a very gentle, what we call goniosnechiolisis, direct goniosnechiolisis with the forceps. And now I can see the trabecular meshwork there, okay? And you've got to be a bit careful with this because sometimes these synechii are not easy to remove, but because these are not pathological synechii due to angle closure or uveitis, these synechii, I believe, can be lysed because they're basically due to a shallowing of the chamber following trabeculectomy. So we're going to go and attack our area again with the trocar just at the edge of the pigmented and non-pigmented TM. And we go in with the trocar, press the button, and the stent is delivered. And you can see there blood beginning to reflux right through the inlet of the stent, which is a really, really good sign. And that tells you again that despite this eye having had 3 trabeculectomies, and you might say, well, I think the angle function would be totally damaged and you wouldn't see any sort of reflux. You do get this reflux. Okay, and so again, you're getting a little bit of blood accumulating around the stent here, and I'm just going to manipulate the stent so that I'm happy it's in the right place. And then, the acid, there you go, you've got some blood coming out there as well. So have a look around here. Again, what we're going to do is as we flush the eye full of BSS, look at that. You can see this blanching of this aqueous vein. So we've resurrected the canal in a patient who's had 3 previous trabeculectomies, and the patient had a very good outcome. Okay, so let me show you some examples of the iStent Inject W. This is a patient who's had a previous he's an Afro-Caribbean patient, previous trabeculectomy, advanced glaucoma, was undergoing cataract surgery on 3 medications. So this is showing you the W. So you can see the flange is a little bit wider there. Again, we're getting reflux through the inlet of the stent. We moved a couple of clock hours across, and then we pop that in there. And again, let's have a look at the episcleral flushing. So you can see the stents are very, very nicely. And so if you have a look over here again, you get some blanching of this area here. So this is another case of Inject W. I'll just go through, move forward here until we show the actual implantation of the stent. So very important to keep everything nice and still, nice and steady. And then you see that you get that reflux again. let's just have a look over here. That's the first one's already been implanted. So that's, you know, a good distance apart. So you get maximum benefit in terms of getting access to all the collector channel network. And have a look here again as we look at that absolutely beautiful reflux or blanching of the episcleral vasculature to show that this stent is in the right place. And, you know, there's been some very nice work done by Alex Huang, who's an ophthalmologist in Los Angeles. And you can see using, this is actual human eyes using ICG in the anterior chamber before and after iStent. You can see really nice blanching of this, or really nice signal out here in the episcleral vessels to show that these stents are definitely working and getting the aqueous humor or the fluid back into the distal outflow pathways. So what are some of the problems that you might encounter? Problems you might encounter are visualization, deployment, you know, failure of deployment, under deployment, over deployment, trocar issues. The trocar might become a bit bent. Adjustment of the stent is important, and you might have occasionally stents which end up in the anterior chamber floating within the viscoelastic. These are all things you've got to be able to deal with. And the other important thing is you don't want to lose a stent in the eye because they are very small, and that is always possible when you start off your learning journey. So you've got to be careful. I'm going to just show you one video here of overimplantation of a W. So this is a patient with pigment dispersion syndrome who's having a phaco plus iStent. And you can see there the visualization could be better, but the reason for that is this is a highly myopic eye, and also in pigment dispersion, the tissues can be quite elastic, and so sometimes you may not get adequate visualization. But so the first stent looks well placed, and again, I'm having problems with visualization here, but you just got to, this is something you've got to kind of learn to manage. And there, so the stent here is slightly over implanted. So we go in with these, and I think these micrograspers are excellent. These are from a company called MST. Ultimate are the distributors in the UK, and I am going to plug them because I think these are MST 25 gauge micrograspers. They're very, very good for manipulating these stents. And now you can see that the whole of the flange of the stent is sitting in the anterior chamber where it should be. So you need to be able to manipulate the stents if required. And sometimes you will see post-operatively in your clinic, if you look carefully at the aqueous veins in patients who've had iStents, you can see there very nice flow of aqueous humor through these aqueous veins. This is on a slit lamp in someone who had an iStents done about a year earlier. So the next question is, and I know Peter Shah alluded to this, is can the iStent get us out of trouble in more complex cases in patients with high pressure disease? I definitely think, you know, it has a place instead of phaco-trab that was used in yesteryear. And I think in advanced glaucoma with cataract, in my view, it's indicated, and it does delay glaucoma filtering surgery. There's good evidence for that. And I think you can even use it in more complex cases such as uveitis. And we've got a small series of uveitis that we did. These were patients with various varying uveitic diagnoses with fairly high pressures on a number of medication. Now, the thing with these patients is all of these patients had cataract, and the difficulty is when you have cataract and high pressure in a uveitic patient, what do? Do you put a tube in because you know if you do a trabeculectomy and then do the cataract, it's going to fail? And I think what's worth considering angle surgery, but you've got to be very experienced because the stents have to be in exactly the right place. Otherwise, you'll end up with a patient who's pseudophakic with inflammation and high pressure. So, like I said, small numbers, but it just shows you the principle that you can get the pressure down. And they're still on a lot of medications, but that doesn't matter because by about 18 months, 24 months, you'll probably be getting ready to do their definitive filtering operation anyway. So that's absolutely fine. This is a series of patients that we operated on sort of, I would say, about 10 years ago with about 3 years follow-up. And these are quite complex patients where we can see pressures coming down from a mean of around 24 on 3.2 meds, which is quite a high disease burden in terms of pressure. And we're getting fairly good pressure reduction with reduction in medication at 3 years. And of this cohort of 50 patients, about 10 of them needed further filtering surgery over this follow-up period. And we also looked at their visual fields. And yes, there were some fast progressors, but actually most of the patients didn't progress following the cataract and iStent procedure. And I'm just going to show you an example of a patient who had iStent surgery done about 10 years ago. This is a patient who was 76 and monocular. He'd already lost his other eye following retinal detachment. And he had Marfan syndrome and underwent a left scleral fixated lens. His vision was 6/9, and he was referred to me with disc damage and a pressure of 28 on quadruple topical therapy. And I did a standalone iStent, and this was using the original G1. We put 2 stents, and that was done in 2011. And just to give you a sort of long-term follow-up, you can see this is the Medisoft printout. The patient's on 3 medications now, and their pressure has been fairly stable over that period. And you can also see this was a visual field in 2011. This is a visual field in 2020. You can see, if anything, the visual field's a bit better. But the point here is that this is a patient who otherwise would have required a Barveld tube operation, and that may well have failed after 5 years. But the point here is that 10 years later, he's not needed a further operation. And that just tells you the power of this technology that, we are now, and I know there is data emerging now around 10 years, but this is 10 years in a very complicated patient. So I'm just going to talk briefly now about this concept of bridge to trabeculectomy. This is where you've got mild to moderate cataract, you've got ocular surface disease. I really believe you need to get the cataract out, do TM bypass, reduce medications, improve the ocular surface. Vision is improved. Gain of trust. The patient then thinks, yes, this doctor has actually helped me. He's improved my vision, and so I can now undergo a filtering operation, which potentially may make my vision worse. But the point is, this gain of trust with these procedures is very important in terms of getting patients on board, which can be difficult in glaucoma sometimes. So let me give you an example of bridge to filter. So this was a 65-year-old Caucasian female who had been under another unit since 2010. Presenting pressure was in the low 20s, and she was seen every 6 months and was compliant with medication. And she was actually a retired teacher. And, when she came to see me, she actually said to me, look, I've been taking my medication religiously, but I've suddenly been told that my left eye has got a lot worse, and no one has ever shown me a field. And anyway, I don't know where the penny had been dropped, but anyway, the patient came to me with pressures of 18, quite a thin cornea, early lens opacity, quite bad ocular surface disease on 3 agents. And if we look at the amount of disease, she had quite significant disease in her left eye and disc damage in the right as well. And these are her visual fields, very, very advanced glaucoma in this eye and moderate glaucoma. And again, I would actually call this advanced glaucoma because it's hitting on fixation here. And according to the HODAP classification, that would actually be advanced. So she's actually got advanced glaucoma in both eyes. So you might say, well, is the iStent indicated? Well, if you go and do a trabeculectomy on an eye, where you've got mild to moderate cataract, the trabeculectomy may fail. You may have to needle a trabeculectomy, and then you have to go back and do a cataract operation. I can tell you the trabeculectomy will fail. So the other interesting thing was when I did a UBM on her, she did have some degree of angle closure, which means she probably has had a mixed mechanism picture. And in this scenario, it's definitely worth taking the lens out. So she underwent bilateral phaco and iStent. Her IOP dropped to about 12 to 14, and she remained on dorzolamide timolol preservative free for a period of 12 months, and then underwent bilateral trabeculectomies with pressures of 7 now in both eyes. And you can see that that's the visual field in 2018 in that advanced eye, and this is the visual field in 2021. And you can see that there's very, very minimal change. So over this 3-year period, we've managed to stabilize her disease. And this is the other eye. So I'm just going to talk briefly now about IOP spikes in glaucoma patients. So these are the reasons for IOP spikes here. Okay, and as Peter Shah said, pre-existing reduced angle reserve is quite an important point, but OVD, lens debris, iris pigment, and so on. Now, if you look at the literature on IOP spikes, there's not a huge amount of literature in this area, but this paper reported that 2 out of 23 patients with severe glaucomatous damage lost fixation following cataract extraction, so that's 10%. And Savage et al. Found that 9.7% of patients with pre-existing advanced glaucoma developed progression of their field. So again, you're seeing a 10% rate of potential wipeout or worsening of glaucoma if you get pressure spikes afterwards. So you really don't want to get pressure spikes. And glaucoma patients are more prone to exhibit these pressure spikes. And if you look at this particular paper by Barak et al., the mean IOP in the glaucomatous group after cataract surgery rose to almost 30 at 8 hours, with 7 patients showing an IOP of greater than 35. And in non-glaucoma group, it only rose to 22. So there's a vast difference in the amount of pressure you're getting after cataract surgery in glaucoma patients compared to normal patients who have a normal angle. So just very quickly, this was a bunch of around 60 patients that we operated on, and we measured their pressure 2 hours post-op and 1 day post-op. So 60 patients, phaco iStent, we did not get, I think we got 1 or 2 patients who had a pressure more than 30, but the vast majority, the patients we found that the patients' pressures had dropped post-operatively. So the iStent really is good at blunting post-operative pressure spikes. And I'll give you an example of a patient who presented to us with very bad disease, bilateral severe glaucoma, bilateral dense cataracts, underwent bilateral phaco iStents, those are his fields. And at 3 years, his pressure was 12 on triple therapy with stable fields. So, you know, in the past, people would have said they need a trabeculectomy, then you can do their cataract or what have you, but we manage them with phaco plus iStent. We're almost towards the end now. This is a series of about 40 patients with phaco and iStent inject, and you can see at 12 months, we're getting pressures down into the low teens. And I think with medication, you can get pressures down in the low teens with the iStent, and that's an important point. So you do have 2 categories of patients. You have patients where you want to get them off their drops, but you've also got patients with more advanced disease that you really want to get them on reduced medication, better pressure control, so you can then filter them later on. And that's just the number of medications. Post-op management, I'm sure Simon's going to talk more about this, but basically, this is what I do. I always say to patients that the final IOP will have an idea around 2 to 3 months, because you can get some steroid response as well. And so I don't sort of say to patients, your pressure is going to be great from day 1, although in a number of patients it is. But, you know, I also always sort of manage their expectations by telling them that we'll get the final pressure at about 2 to 3 months. Complications, we've talked about malpositioning, lost stent. If you do, I have had a couple of patients sent to me with lost stents, and you can find them using ultrasound biomicroscopy. And in this case, the patient's stent wasn't in the ciliary body, but you can leave them in the ciliary body, it doesn't cause a problem. You can get a lot of bleeding, and you can get hyphema if you're not careful. So just watch out for that. I think generally the rate of hyphema is very, very low, virtually negligible. And this is an example of the case where the stents are actually in the ciliary body. This is the actual trabecular meshwork is here, the spur is there, and these are in the ciliary body. So just to summarize then, it takes time and effort and persistence to incorporate a new procedure. There is actually a huge amount to observe and learn, and I think this is a key: observe. Keep in all areas of medicine, observation is very important, because a lot of these things that we observe as clinicians are not necessarily in the books or in the papers, and patients are not all the same. It's very important, and make sure all the governance boxes are ticked. And good luck. So I'm just going to stop sharing my slide there.
Thanks, Imran. Excellent presentation, as always. Quite a number of questions in Q&A. Also a question in the chat.
Okay, so let's have a look at the questions then. Okay, so let's go on to the chat first. So PAS surrounding the iStent is a well-described sequelae of using the device. How do you think this impacts on the long-term success of the device? Well, I think the question is, why are you getting PAS around the stent? Now, I think that in patients who have very deep angles, okay, so I think this depends on the angle morphology. If you've got a nice deep angle, PAS are very unlikely. And I think that often one of the things that we kind of neglect to take into account is something called the iris insertion. The iris insertion can be a bit higher in some patients, and that means that the iris is nearer to the iStent. Now, I think that if you are dealing with a patient who has quite high pressure and you get iris plugging the stent, that will no doubt impact on the success of the device. Some people have described using the YAG laser to try and free the PAS from the stent. In my personal opinion, I think the lumen of the stent is so small that once you get iris plugged inside the stent, I think it's very hard to deal with it with a YAG laser. I don't have any personal experience of that, but I certainly think that PAS, particularly iris prolapsing into the stent lumen, will have an impact on the success of the device. Do you therefore check IOP in 2 hours? Okay, very good question. So I have now stopped checking pressure at 2 hours because my initial study showed that at 2 hours the pressure is fine. In patients who have very, very advanced glaucoma, who perhaps are monocular, when I'm doing cataract surgery on them, I will keep them in the hospital. I will check their pressure at 2 or 3 hours later. But I've never found it's high, but that's just from the point of view of the fact that you don't want any risk with this patient, so that therefore in those I will. But for the vast majority of patients, I actually don't even, the straightforward patients, I don't even see them on day one anymore. I would actually see them at week 1, because once I know that the stent is in the right place and I get good episcleral flushing, I know that the patient's not going to have a problem. So what I tend to do in terms of seeing patients is I will tend to see routine patients now on week 1 and then around month 1. With PAS and previously trapped, is it work? I'm not sure what's the question. What about the cases with PAS and previously trapped cases? Will it work in the future? I think, as I showed you in this example, I think my view is that if you've got a failed trabeculectomy, and you've done, and you potentially can lyse those PAS, but it depends on the pressure. If you've got someone with a pressure of 40 or 50, and they've got PAS all the way around and they've had a previous trabeculectomy, I probably wouldn't recommend going down the iStent route. Because you might find that that the angle is well and truly damaged. In the case that I described, the pressure was around 21, 22, around that level on 3 medications. So there was a little bit of room to maneuver. So I think that yes, in patients who have failed trabeculectomies where the pressure isn't too high, I think when you're going in to do a cataract operation and these patients are on 3 or 4 meds, I think it's completely reasonable to think about doing an iStent. Could you tell us more about your experience with uveitis and iStent? So I think really my experience is what I've shown you in the presentation already. I think when you've got a cataract patient with uveitis, I think, and you've got a nice open angle, really important. Sometimes in uveitis you will have inflammatory PAS. Do not do it in those patients because the PAS in uveitis are very different because you may get some vascularization within the PAS. You may get bleeding and so on. So, and also you can cause more inflammation. So in uveitis cases, I would go for the patients who have open angles. Okay, I found that certainly herpetic eyes. Remember, the patients who have herpetic uveitis tend to have a trabecular failure, trabeculitis they often get, and so the iStent may work well in those patients. Right, I think, Niven, shall we move on to the next talk and then carry on with the questions at the end? I can't hear you, Niven.
That's fine, Imran. Could you take perhaps one more from the Q&A section? There's quite a few mounting up there, and then we'll deal with the rest of them later.
Okay, let's talk about, can you use, let me do 2 or 3 quick ones. Can you use Trypan Blue? Yes, you can use Trypan Blue, absolutely. It's a nice technique, but I don't use it because if you're getting blanching with the BSS, you don't really need to waste Trypan Blue. Is it possible to implant more than 2 stents? Absolutely. I think the iStent Infinite is coming out, which will have 3 stents on it. Inflating the eye causes Schlemm's canal to flatten. Okay, so I think some of these Simon is going to cover. So I think we'll come back to the questions at the end. So next, it gives me great pleasure to introduce Mr. Simon Dulku, a good friend and colleague, and he's going to talk to us about his data, but also very important issue of patient selection. So thank you, Simon.
Thanks very much, Imran, and thanks for inviting me today to talk. Okay, is my screen sharing okay there? Great. So really the outline of this talk is just to go over some of selected evidence about the iStent injector, and the iStent for which there's a lot of evidence, and some of those slides were supplied by Dana Hornbeek, which I'm very grateful for. And then just to talk about my experience, so how I approach patient selection, and then some real world data from my first 30 cases, and then a case example, followed by a discussion. So I hope some of the evidence will I'll be able to present some of the evidence for you. So the iStent has the most number of publications, peer-reviewed publications for any MIGS device. It's the device that's been around the longest, and there's the longest amount of long-term follow-up for the device. And I'm going to start by talking about the pivotal studies and formal trials that were done for approval of the iStent. So the pivotal trial had 24-month endpoints, and it was a prospective multi-center trial with a 3-to-1 randomization of the inject plus phaco and phaco alone. And there was 24-month follow-up for these patients, and they also had a washout of medications at baseline and a washout once a year, the purpose of which was to remove any sort of confounding factor of the medication in the endpoints. And the primary endpoint was a greater than 20% reduction in unmedicated diurnal IOP, with a secondary outcome measure of a mean reduction in unmedicated diurnal IOP. And then all these patients were then invited back for a 3-year visit to get longer-term follow-up data. So the results demonstrated that there was a mean intraocular pressure decrease greater in the cataract plus iStent group versus cataract alone, and a larger proportion of patients had a greater percentage reduction in intraocular pressure in the cataract and iStent group. And looking at the medication-free intraocular pressure, that was again lower in the cataract with iStent group versus the cataract-only group. The other way of looking at the data is what percentage of eyes were medication-free and with a greater than 20% reduction in intraocular pressure. And again, looking at the data in that way favored the iStent and cataract group. A larger group of patients achieved that endpoint in the combined group versus the cataract-only group. And in terms of safety, what was important, and I think this is something that Imran has already spoken about, is that there were not that many patients needed to have trabeculectomy at 3 years. Only 1% of patients in the iStent group needed a trabeculectomy versus 3% in the cataract surgery group. And really importantly, there was no significant difference in the endothelial cell counts. And given that there's been recent safety concerns with MIGS devices and the endothelium, it's really important to see that the iStent doesn't seem to be having a detrimental effect on the endothelium. There's another trial here from Robert Fechner, and this was comparing iStent alone with Travatan, so this time not in conjunction with cataract surgery. And the results of this study showed that you got a similar reduction in intraocular pressure using iStents versus using prostaglandin. And there was actually a slightly greater percentage of eyes achieving treatment success without medication in the iStent group versus the travoprost group. There's also a lot of real-world evidence in the literature. So again, talking about long-term follow-up, in the Manchester iStent study, they have now got 7-year follow-up, which is the longest term publication of any MIGS device. And their study is showing a continued reduction in intraocular pressure even at 7 years. And interestingly and importantly, patients who are at risk for filtration surgery had especially marked pressure reduction, and only 30% of those patients needed additional glaucoma surgery at 7 years. So even in these advanced cases, at risk of filtration surgery, the iStent does seem to be protecting patients from needing further treatment. There's also standalone data in the real world from Henger et al. Looking at the iStent inject as a standalone treatment, again without cataract surgery. And they found that he had 3-year follow-up data. And what was interesting is that the inject on its own seemed to give similar results to the inject with cataract surgery. And so it may be that the effect that we're seeing after cataract surgery is mostly the effect of the iStent rather than any additional effect being provided by cataract surgery. And there was a 80% reduction in medications as well after 3 years in the iStent solo group and a 68% reduction in the cataract surgery group. And I think what's important as well in looking at this data is it's not just intraocular pressure reduction that we're looking at, but also this intraocular pressure reduction is often achieved with a concomitant reduction in the number of medications. And that has positive effects on the ocular surface and on quality of life in glaucoma. There's an Australian study, a pooled study, 9 surgeons, 340 eyes. This is the iStent inject implanted with cataract surgery with mild to advanced disease, so the whole spectrum of disease incorporated in this study. And again, this showed sustained reductions in intraocular pressure at 2 years and reduced medications. The medication burden was reduced by 67%. So from about 1.5 medications on average to about half a medication. And 13% of eyes were on greater than 2 medications versus 46% at preoperatively at 2 years. And then talking about additional benefits beyond intraocular pressure and medication reduction. In so looking at quality of life, which is very important and something that's often overlooked in studies on glaucoma, there was a greater quality of life benefit in patients treated with the iStent inject versus cataract surgery patients alone. And this is partly due to ocular surface improvements and also due to reduced need to put in medications. And looking at the ocular surface, there's a very large body of evidence showing detrimental effects of chronic medications in open-angle glaucoma. You have worse ocular surface disease, and then that leads to a high risk of surgical failure. And the iStent inject reduces the medication burden, and this is really what Imran was talking about as a bridge to trabeculectomy. If you can deal with the cataract, reduce the medication burden for 6 to 12 months prior to trabeculectomy, you'll have a happy patient because they can see better, but also you can improve the chance of your trabeculectomy working well by reducing the medication burden prior to surgery. And they also showed that there was an improvement in the ocular surface symptoms in these patients with the OSDI questionnaire. Again, and that was achieved with a concomitant reduction in the number of glaucoma medications. So it suggests that the iStent inject is having a positive effect on the ocular surface due to a reducing medication burden. So talking about starting out, in most of us, I think, will be using the iStent at the time of cataract surgery rather than as a standalone procedure. I think all patients with glaucoma, all patients on topical medications will benefit from iStent implantation at the time of cataract surgery. The chances are that those with early glaucoma or ocular hypertension will benefit the most. However, it's been my experience, and I think the same goes for Imran, that there is better pressure control in patients with more advanced disease as well. And therefore, it does appear that all patients with glaucoma should be considered for iStent implantation. The other benefit of the iStent is a one-off procedure, and it can give benefits over 5 or more years compared to, for example, anti-VEGF injections, which we have to give every 6 to 8 weeks. So it's a one-off procedure that has long-term positive effects for the patient. Now, talking about inclusion criteria when starting out, I think Imran is right in that you probably want to take on the more mild patients in your first cases, although because of the nature of my practice and starting cataract surgery within my service, I actually took the opposite view that I needed to reserve the iStent for the patients with the most severe disease. But having said that, over time, as I've used the stent more and more, I've used the stent now for almost all patients with glaucoma or who are on medications because of the positive effect that it has on their post-operative pressure control. In terms of post-operative regime, I make sure that everyone stops prostaglandin analogues, and I find that the iStent helps with that because I don't have difficulty managing their pressure afterwards, because we've already seen a study that demonstrated that the iStent was equivalent to Travatan in terms of its efficacy. I give iopidine 1% as a stat pre-op dose to reduce the vascularity of the eye, and I feel that that reduces any risk of bleeding. I give Diamox for a various number of days if there is significant field loss. In patients that don't have significant field loss, I don't give Diamox. I give quite intensive steroids to start with for the first week or so and then taper. And I tend to give patients Cosopt or Azaga, depending on contraindications, plus iopidine for 7 to 14 days in order to keep the pressures as low as possible, because most of the patients that I'm dealing with do have moderate glaucoma. I actually do review patients post-operatively and on day one. And I know Imran doesn't do that, but I do feel that with the eye care now and not needing to do GAT post-operatively, it is quite easy to do a post-op pressure check. And the other advantage I find of a day one or day two review is just that you can explain the drops again to patients, because a lot of my patients are very elderly and a lot of them are not always clear on what drops they need to take. So getting them back into clinic and being able to explain that to them is quite important. Then I sort of spread the follow-ups out to week 1, week 3, and week 6. And the main reason to see them that frequently is there is, even with the iStent, although the risk of post-operative pressure spikes is less, you can occasionally get caught out with somebody who's a steroid responder who gets quite high pressures. So I do tend to just, and the follow-up appointments don't take very long. So with those kind of inclusion criteria, which were quite advanced cases, what sort of results could you expect in your first 30 cases? And these were some results we presented a couple of years ago at ESPRIS, which showed a reduction in mean IOP at 6 months and with a concomitant reduction in medications. So the patient started off at roughly 2.1 medications on average and reduced to 1.6. And you can see across the board, really, the pressures were well controlled at all time points. A different way to look at the data is the individual patients pre and post-operatively, and looking at the change in pressure. So the vast majority of patients, there was some, for example, that started low and finished low, and in those there wasn't much change. But in most of the patients that started with high pressures, there was a significant reduction. Some of them by 2 millimeters of mercury, and actually quite a significant proportion by much more than that. In terms of patients on this that I would have been less happy with, there was a couple of patients who started in the mid-teens and ended up a little bit higher, and a few patients where there wasn't much difference. So there's probably 6 patients out of the 30 I was disappointed with, but all of the other patients either started low and remained low, or started high and had a significant reduction. Now, since that time, I've done a much larger number of iStents, and I've actually just gone onto Medisoft today to actually get my latest figures. And these are completely unvarnished figures that are straight out of the electronic patient record, and I haven't corrected them for comorbidities or anything like that. So I've done 319 phaco iStent procedures, some of which will have been done by fellows, maybe 30 or 40. The rest were done by me. If you look at the preoperative pressure, the mean was about 17 with about a 6 millimeter mercury standard deviation. And these patients had an average mean deviation of about -8. So moderate disease, and some of them obviously were advanced, which pulls that mean deviation lower. Post-operatively, pressures were much better with a much narrower standard deviation, and visual fields were slightly better, probably relating to the effect of the cataract surgery. But the key point really is that the patients are not wildly out of control. You know, the starting pressures were about 17 to 23. So I'm not taking patients to theatre that are out of control, but these are patients that maybe have suboptimal pressure control, or in whom I want to make sure they get good pressures after surgery. The follow-up, I've got some patients now that are 2 years, and the main thing to take home really from this is just to say that there was a reduction in patients on 2 or 3 medications, and a lot of them were reducing down to 1 medication. But probably the medications haven't reduced as much as you might expect, and that's just because of my patient cohort. I'm aiming really for lower pressure rather than getting people off medications. And as Imran explained, there's sort of two aims of the iStent. One is for better pressure control, or the other is to reduce medication burden. And it depends on your patient which one you're trying to achieve. And if we look at the percentage reduction from baseline, almost 50% had a 20% reduction, and quite a large amount, 30%, had a third of patients had a greater than 30% reduction from baseline, which I think for a device that with practice takes 10 minutes to implant with a very good safety profile, I think a fantastic result. And to put it into context, these are my results for trabeculectomy, a much more invasive procedure. And even with trabeculectomy, only 70% of patients were getting a 20% reduction. Partly because not all patients start with a high pressure, but even with trabeculectomy, the gold standards, the iStent results I think are compare quite favourably with the trabeculectomy results. So just to go through a case presentation, and the reason to go through this case presentation is to just illustrate how the iStent can help you in difficult cases. And at the very beginning of this seminar, Pete Sharp talked about the brittle angle and the brittle optic nerve, and this patient actually had both. And you'll see during the case presentation where I may not have called the ball correctly with his first operation. So this is an 80-year-old Caucasian man with normal tension glaucoma. He had full fields at the time I took him to surgery, but had very cut discs. And a phrase Pete Shah uses for these discs is that cliff edge discs, because although the field is full, any further damage to the disc can lead to a catastrophic loss of visual field. He was a high myope, which carries certain risks, especially with steroids post-operatively and high pressure. And he had visually significant cataracts and needed surgery. So these were his preoperative pressures. They're sort of between 15 and 20 on treatment. And these were his preoperative visual fields and preoperative OCTs. So he had intraocular pressure phasing, which showed sort of borderline pressures, suspicious discs, and we had a discussion and agreed to proceed with surgery. Now, there was a bit of a complication in terms of performing iStents for his right eye, in that he was on warfarin for atrial fibrillation, and I do find that stopping warfarin or apixaban is important before iStents to reduce the risk of bleeding. I don't stop aspirin or clopidogrel, but the warfarin and NOACs, it's important to stop. And I wasn't keen to stop his warfarin just because of the risk of stroke. And we had actually had a patient undergoing ptosis surgery who died of a stroke after having their warfarin stopped for 5 days. So I was a little bit wary of stopping warfarin in patients at that time. So we proceeded to do his right eye without the use of an iStent, but unfortunately I got very, very bad post-operative high pressure due to the steroids. And despite attempting to put an iStent in afterwards, at that point, after he'd already had high pressure, the iStent wasn't effective. So there's an argument to say that the iStent is more effective at the time of cataract surgery. Once you've had high pressure, you may cause further damage to the angle and collapse of lens canal, and the iStent may not be able to rescue you after surgery. So I needed to proceed to a trabeculectomy, and after performing trabeculectomy and weaning him off the steroids, I did manage to get control of the pressure again, but that control came at a price, and that price was quite a lot of further damage to the disc and a significant worsening of his visual field, which he has noticed, and he does feel the vision in the right eye is worse. So then the question came what to do about the left eye, because the visual acuity was quite bad in the left eye, and he really was struggling with his left eye, and also had significant anisometropia now following his cataract surgery. So this time I decided to proceed with an iStent to see if that would, but counselling the patient that he may well need a trabeculectomy if I have the same problem with his pressure control. So it was a difficult case, a very dense cataract. He needed iris hooks. There was a little bit of hemorrhage during the surgery, possibly from the iris hooks. And I think for me that underlined the importance of stopping warfarin in these cases, because there was a small limited hemorrhage, and I think that would have been much worse without stopping the warfarin. In terms of the pressure control post-operatively, I was very careful to follow him up regularly, but the story couldn't have been more different. This time with the iStent implanted at the time of cataract surgery, I didn't have any issues with his post-operative pressure control, and his disc has remained healthy in that eye with a fantastic visual field. So, and these are his latest pressures at his last appointment. So controlled in both eyes, but with a much better post-operative course in the left eye. And he still does feel that his right eye is now not as good as the left. And you know, duty of candor is very important, and I did apologize to him, but ultimately it was at the time I made the decision to do the right eye, it really was a risk-benefit profile of stopping the warfarin. But in future, especially with myopes, I'll be very careful, because I think they are particularly prone to post-operative pressure spikes because of steroids. So in summary, we've reviewed the literature and evidence supporting the use of iStents. We've discussed patient selection, and whilst I may have chosen the highest risk patients to use the iStent on, I think in most people's practices it would be appropriate to pick lower risk patients to begin with. I've suggested a post-operative regime that's suitable for my practice, which is a lot of patients with glaucoma, but you may find that you don't need to be as strict depending on your case mix. You see my results for the first 30 cases, and also the general results for about 300 cases now that I've done, and a case illustration where not using an iStent resulted in a poor outcome that I managed to avoid in the other eye by use of an iStent. So thanks very much for listening.
Thank you very much, Simon, for an excellent presentation and some very interesting data. I particularly like the comparison you've done with the trabeculectomy. I think that's really, really interesting to say that the iStent is only 50% less effective than a trabeculectomy for the amount of work you're doing. I think is fantastic. So that's really good data. So I think what we'll do is we'll start going through the questions because there's quite a few. We've got about 15 minutes before we end. Let's go. I think we'll go to the Q&A because I was going to pick up some from there. So, okay, Simon. So this is a question I will. Let me pass this on to the most experienced surgeon, Professor Shah. A slightly controversial question, but the question is, who should do this iStent? Glaucoma surgeons only, or should any intraocular surgeons do this? Peter.
That is a very good question and a very tough question. I'm going to give you my own personal view, but be mindful of the fact that in different territories there are different ways of practicing medicine. So I suppose I'm giving you a UK answer. In the UK, the majority of glaucoma patients are looked after by people with a special interest in glaucoma. And I would probably recommend that glaucoma surgeons do the majority of mixed procedures. However, for those surgeons who are extremely experienced anterior surgeons and can deal with the complications of mix, i.e. implantation into the wrong place, huge pressure spikes post-op if you get a bleed, then I think it's absolutely fine for them to manage. What I think is probably not acceptable is for a surgeon to run into trouble with putting in a MIGS device and then be trying to send on a patient with a high femur or a pressure of 50 onto somebody else who has no knowledge of that patient. I don't think that's acceptable, and that's not best practice. I don't know what you think though, Imran.
Well, let me ask Simon first of all. Simon?
Yeah, I know. I think I agree with Pete there. I think I think the key is to can you manage that patient's journey, I guess, through their surgery. And it may be the case that you have a glaucoma consultant you work, or somebody with a glaucoma specialist interest that you work closely with, that is happy for you to do those procedures on maybe lower risk patients to spread the burden of work. But you do need to have a referral pathway, I think, if things don't go right.
Yeah, no, I think both of you have kind of hit the nail on the head. And I think Pete made the point about different practicing environments, and that is relevant. But I think the bottom line is, if as a surgeon you're going to do a procedure, you have to know the indications, contraindications, complications, and be able to manage those. I think that's very important. What you shouldn't be doing is biting off more than you can chew. And certainly I think that, I know a lot of non-glaucoma specialists look after glaucoma patients. And I think the key is to stay up to date with glaucoma management. If you're going to look after glaucoma patients in your practice, and you're monitoring them, you're attending all the CPDs around glaucoma, I think there's no problem with that, so long as you're an experienced anterior segment surgeon. I think it's absolutely fine.
Imran, I think in our practice, you and I picking up super regional cases, yeah. I would say one of the biggest problems is people selecting the wrong sequence and timing for surgery because they weren't glaucoma surgeons. So it's almost a step before MIGS, yeah. Getting that right as well.
Yeah. Okay. So Simon, if I can ask you this question, because I know you introduced the iStent to the QE some years ago. How do you convince an unwilling district hospital trust to permit trial and eventual adoption of iStent because of its financial cost? And I think you made a very good point about the relative cost of the iStent versus intravitreal injections. And I think that's a really important point. But how would you convince a trust that wasn't, or to permit trial and evaluation and adoption of the stent?
Thanks. No, that's a really important question. I think first of all, it's helped recently, and when I say recently, in the last 3 or 4 years, that the tariff, if we're talking about UK practice, which I assume we are, the tariff for the procedure does cover the cost of the iStent, the new tariff. And I think there was a time when the tariff didn't cover the cost. So the first thing to say is that the procedure is doable within tariff, so that it shouldn't cost the hospital any money on a payments by results system. The second thing, I mean, the way I got it approved in the end was sometimes in our trust that they sometimes recommend that you go straight to the top, and you don't, that sometimes things get blocked in middle management. So, and I was finding that I couldn't manage certain patients through their cataract surgery journey. And I think something that doesn't come out in the papers is this issue of pressure spikes and problems. And I was spending a lot of time in clinic dealing with patients who were having pressure spikes and issues after cataract surgery. So I found that with the iStent, that was much reduced. So I think it streamlines the patient pathway. There's certain patients that you can manage that you otherwise couldn't manage. And I think that I have found that I couldn't manage my practice anymore without the iStent. So I think there's clinical reasons, but also I think it is within tariff. And I think that the final argument I guess I would use is capacity. So if you can convert some patients to phaco iStent instead of needing to do as many trabeculectomies, you don't need to save many trabeculectomies to actually really increase your clinic capacity, because that's the key. Is a lot of us are short of capacity, and I think having the iStent in your pathway does make that much easier.
Yeah, no, I think those are all very wise words, and I think that given Simon's background as the clinical service lead, I think there's a lot of important points you've made there. I hope that helps the person who's asked the question.
Imran, I do have a comment on that as well. Is it still today in the UK, the second most common cause of preventable sight loss is glaucoma. So there's people still losing vision in the UK because for whatever reason, they're presenting late or not being treated adequately. And if we can treat some of these patients earlier at the time of cataract surgery, it may be a once in a lifetime opportunity. We're now seeing some long-term stable visual fields, and we may be able to prevent some of the sight loss that is happening. So that's another strong argument. But the capacity issue by delaying or not doing trabs, you're going to still do lots of them because of the aging population, but it frees up a lot of clinic time, and that's one of the really strong arguments to the business managers.
Yeah, that's great. Okay, so next question we'll ask. Inflating the eye causes the Schlemm's canal to flatten. Does it make it difficult to implant the iStent, especially for beginners? So I'll take that. Yes, the answer is yes, it does. So the key thing is do not overinflate the eye with viscoelastic, because what you want is you want the stent, the head of the stent, to be able to get into the canal nice and easily. So there is a balance between how much viscoelastic you put in the eye. You need a sufficient amount to be able to pop the gonio lens on without the cornea flattening and getting striae. But I think you need to be careful how much you put in, because you might have problems with the Schlemm's canal. So that's that one. Okay. So if I can ask Simon this one. Simon, any views about stopping topical prostaglandins perioperatively?
I think, and Pete may have some comments here as well, but I think I think what I found in an NHS practice is that to stop a prostaglandin, I think it's a good idea. If you can stop prostaglandins preoperatively, a month or before surgery, I think that would be the gold standard. My main issue is that I feel in an NHS practice, I can't then see the patient to check their pressure, a couple of weeks after doing that. So I think if you are going to do that, you ought to check the patient's pressure is still controlled. And I feel that I just don't have the capacity to do that. But I think if you can incorporate that into your practice, I think it is a good idea. I don't know what Prof. Shah thinks.
I don't know who asked the question, but I think it's a very good question about stopping prostaglandin analogues in glaucoma surgery. And I think this is where you need to keep up to date with the knowledge base. There's a good emerging database now that prostaglandins are pro-inflammatory and they cause pro-inflammatory sequelae post-phaco. Now, as a suprarenal specialist, I have lost count of the number of eyes I've been sent over the years with massive loss of vision through intractable cystoid macular edema, through keeping people on prostaglandin analogues post-op. So what kind of pearl can I give you? Well, first of all, I stop all prostaglandin analogues at the time of surgery and keep patients off them for 8 weeks post-op before restarting them. There's very good evidence that the blood-aqueous barrier after phaco surgery is broken down for a lot longer than we think clinically. And for all those eyes with suboptimal blood-aqueous barriers, that's everything from angle closure, pigment dispersion, pseudoexfoliation, uveitis, severe OSD, other secondary glaucomas, maculas with ERMs, VMT, systemic diabetes, COPD, ethnicity, African, Caribbean, Indian, Asian. There's so many eyes which are prone to CMO. And for those people who say they don't get CMO, well, you don't get CMO if you stop the prostaglandins and give plenty of steroids. But the National Ophthalmic Database figures for the UK are pretty damning on post-op CMO. The rate is far too high at about 4%. It should be at least 2 decimal places less than that. So please think about stopping prostaglandins after cataract surgery. It does not do the eye any good at all.
Thank you very much. I think that's fairly clear advice. So there's a question here about the iStent injector. So I'm finding the W injector more tricky to deal with compared with previous generation. I'm just wondering, do you have any tips to prevent the dislodging of the stent while implanting it during the surgery, directly after withdrawing the trocar? Thank you again. Simon, do you have any thoughts on that? So I think what the person asking the question is and I have noticed this is the idea that once you've implanted, when you pull the trocar out, you've got to come out perpendicular, okay? Otherwise you can actually, the trocar, because it's a slightly bigger stent, I think there's a bit more friction between the trocar and the actual inside of the inlet. And so there's a risk that if you come out in not the exact same plane that you went in, you might pull the stent out or dislodge it. Any thoughts on how to avoid that?
Yeah, totally agree. I think you do have to try and come back in the same track that you took to put the stent in. And the key, and I think all the surgical trainers at Glaukos do teach this very well. I think it's always to make sure that you do a press and hold and withdraw the stent, because if you do let go of the button after you've implanted it, you will dislodge the stent, because that small movement of your finger will be enough to dislodge the stent. So it's a press and hold, and then coming out in the same, you almost have to memorize the route that you took in and reverse that as you come out. Okay,
yeah, no, I agree with that. Another question, this is, I think I will pass this on to Professor Shah, who's been the ex-president of BOAS. In cases with advanced glaucoma, do you prefer to do the surgery under GA or topical to avoid the additional risk of wipeout related to the LA? Is the iStent doable under topical? Peter, if you can answer the question about GA, and I will then take the issue around wipeout related to LA and topical.
Yeah. So again, these are really good questions. There are lots of technical considerations that are going to move you towards GA or LA in any individual case, particularly if you do a lot of only eye surgery like we do. However, if you're going to use general anesthesia in advanced glaucoma, there is one pearl I would give you, and that is that your anaesthetist must have adrenaline or a vasopressor in their right hand while they are putting the patient to sleep with their left hand, because you can get a plummet in blood pressure on induction, and that's enough to wipe a patient out. And sadly, I've had patients sent to me over the years where precisely that has happened. So the pearls are, don't get the patient dehydrated pre-op. So someone with an only eye at high risk of wipeout, they need to have a drip up, so they're not getting dehydrated during the day, particularly if their surgery is a bit later in the day. And at the time of induction, the anaesthetist must have a vasopressor present, and the anaesthetist needs to be told not to drop the blood pressure during surgery. So I hope that's helpful, Imran.
Yeah, so I'll just pick up that. That's very, very helpful. I'll pick up the point about the topic. So my view is that actually, if there's a reason for doing the surgery under general anesthesia, you should do it, as Peter says. But I don't think GA is safer than LA. With LA, if you do the surgery under subtenons anesthesia, the subtenons is very unlikely to cause a wipeout. If you look at the papers on this, people have done studies on the increase in orbital pressure following a subtenons versus a peribulbar. Peribulbar is much higher risk in terms of these kind of eyes. So I think a subtenons is actually very safe, and I would recommend subtenons anesthesia. I wouldn't recommend topical because I know in other parts of the world people do topical. My problem with topical is that although you can do cataract surgery under topical anesthesia, because when you have the instruments inside the eye, you have control of the eye. The problem with doing angle surgery under topical is if the patient moves their eye, you have absolutely no control. and I have actually personally seen massive iris root dialysis from a surgeon who was trying to do this under topical, and the iStent got caught in the iris. So my advice is do not do these under topical. Okay, so next question is...
And we've probably got time for 2 more questions,
okay,
because I think we want to wrap up. Unfortunately, I don't think we're going to be able to answer all the questions. But
okay. Let me just choose some relevant ones then. I think the post-op region... Okay, I think we'll look at this one. Do we have to implant the iStent nasally? Okay, I think the studies have shown that from an anatomical and physiological standpoint, most of the collector channels are actually on the nasal side. And so my advice would be, yes, you do have to implant the stents nasally. Could you go from the top? Potentially you can go from the top, and I have certainly in very rare instances done that. But I think that if you are a cataract surgeon who likes operating from the top, and you're fixed in your ways, I mean, I think generally certainly all new glaucoma fellows, when they come to me, I say, look, as a glaucoma surgeon, nowadays you have to be operating from the side. You cannot operate from the top. So, but if you are fixed in terms of your technique, then I think the best thing is to make a second incision temporally. It doesn't have to be a huge incision, because a small incision can accommodate the iStent inject delivery system. So I would certainly go temporally. Okay. We've talked about that. Okay, I think we'll leave it there. Thank you very much for the questions.
yeah, good discussion. Thank you, everybody. And once again, thank you ever so much, Imran, Prof. Shah, Simon. Excellent presentations, very informative. And thank you to all the delegates and Glaucos team for attending. So enjoy the rest of your weekends, and thank you very, very much, everybody, for presenting and attending today. It's been very informative. Thank you.